हेलो, गुड मॉर्निंग जी। आपका तो लीजिएगा, इनको लाजमी कैविटी है, तो उसको कैविटी को फिल करना पड़ेगा। और अगर पेन है तो फिर रूट कनाल करना होगा। पेन अगर ज़्यादा है तो रूट कनाल करना होगा। नॉर्मल स्टेंस होती है तो बिल्कुल ही से कम चल जाएगा। ठीक है, तो क्लिनिक पे यहाँ जाना पड़ेगा और वहीं पे ओके।
Yeah. Okay, so today we are going to discuss about abdomen. This is the basic abdomen anatomy. In the picture, and this part already we have seen. Very rapid view. This is the gross idea about the orientation of the organs inside our abdomen. And this is the posterior view, and this was anterior view. And then these are the quadrants of the abdomen. We can divide either in this simple 4 quadrants and this 9 quadrants. Important landmark transpyloric plane. We need to know what are the structure remains in the transpyloric plane. If we start with stomach, it becomes easy. So we can see here the first structure will be the pylorus of the stomach. Then second part of the duodenum. As we said duodenum, we will say other structure related with duodenum, that will be duodenojejunal plexus. So 3 structure we cover. One is pylorus of the stomach, then second part of the duodenum and duodenojejunal plexus. As we got some flexor, we will cover 2 flexor. One is in the right side, another one left side. In the right side we have liver, so it is hepatic. Liver is hepatic flexor of the colon, and another one splenic flexor of the colon. So we covered 1, 2, 3, 4, 5. Okay. As we mentioned here colon, we will say something about mesocolon. Which part? Root of the transverse mesocolon. Root of the transverse mesocolon. Then we have liver, another important part of the gallbladder. Which part of the gallbladder? Fundus of the gallbladder. This is exam question. Which part of the gallbladder remains in the transpyloric plane? Fundus of the gallbladder. Yeah. Then fundus of the gallbladder. Exactly, fundus of the gallbladder will remain in transpyloric plane. Fundus of the gallbladder. Okay. Then we need to think about the solid organ. What are the solid organ we have? We have liver, we have spleen, then we have pancreas, right? And the hollow viscous, we have stomach, we have duodenum, we have jejunum, and we have colon. In this way also you can remember. So solid organ we already covered, that is spleen, pancreas, and fundus of the gallbladder. Neck of the pancreas. Now other solid organ we have kidney, right? We have kidney. So kidney, which part remains there? Hilum or hila. So left one, remember, hila of the kidney, especially the left one. Left one, L1. You remember in this pattern. Left one, L1. Multiple times this exam question repeats. Left one, L1. Left one means which one? Left kidney. Left kidney remains in which level? L1. Okay. Then spleen. Hilum of the spleen. Yeah. 9 costal cartilage. Then important spinal cord, which part? Termination of the spinal cord. Termination of the spinal cord and beginning of the corner or superior portion of the conus medullaris. Okay. Important artery, which artery? Origin of the superior mesenteric artery. We got artery. Now we need to think about vein. Here you can remember in this way, we have nerve, then artery, then vein. Which nerve? Nerve means spinal cord, the biggest one. Yeah. Termination of the spinal cord, artery. Which artery? That will be the superior mesenteric artery. And vein, which vein? We have portal vein. portal vein. How it forms? We need to remember portal vein forms by the union of splenic vein and the superior mesenteric vein. Splenic vein, this is splenic vein, and here we have superior mesenteric vein. Splenic vein and superior mesenteric vein, they join together to form the portal vein. And portal vein also remains at the L1 level or transpyloric plane. And cisterna chyli, the beginning of the thoracic duct. So these all are the important structures. This is very, very important topic for any exam, anatomy, any exam. Cisterna, no, cisterna chyli is the collection of the chyle, all the chyle, like this. It will be like. Yeah, it's a structure. It's a structure. Thoracic duct, cisterna chyli, the beginning of the thoracic duct. This part is called cisterna chyli. It is like something a bigger structure. We will see this structure in the next we have. So here we need to remember umbilicus remains at thoracic 10, inguinal ligament at thoracic 12. These are the dermatome level. Okay, not the vertebral level. These are the dermatome level. Dermatome, umbilicus dermatome at the level of umbilicus dermatome at the level of T10, inguinal ligament at the level of T12. Okay. In inguinal L1, inguinal L1, inguinal L1, inguinal L1, and gluteal. No, L1, L1, L1. It is L1. This is L1 because inguinal will be from anterior superior iliac spine to pelvic suprachiasm. Yeah, because it should see the L1 distribution. It is doing in this pattern. So if we want to do some surgery here, this part also should be numb. Otherwise, patient will feel pain. But no need to go beyond this level. The inguinal hernia incision is made above the groin fold. So anesthesia should involve L1 because here we give incision almost in this level. Okay, so it is coming up to this area. If we don't cover L1, patient will feel pain. You got it? From here, just need to remember superior epigastric artery comes from internal thoracic artery, inferior epigastric artery comes from external iliac artery, and superficial epigastric artery comes from femoral artery. Also, superficial circumflex artery comes from femoral artery, but deep circumflex comes from the external iliac artery. Exam related, only important, superior epigastric artery comes from superior. So this is superior from the anatomical location you can see. This is superior thoracic artery. Superior epigastric artery. Superior epigastric artery. Superior epigastric artery, and it is coming from the inside the thorax. So see, this is the internal thoracic artery. Internal thoracic artery, it is coming from the subclavian artery, and it is giving supply inside the thorax, and from there we are getting superior epigastric artery. So conclusion, superior epigastric artery comes from internal thoracic artery, and inferior epigastric artery comes from femoral artery, external iliac artery. Inferior epigastric comes from external iliac artery. External artery, yes. Yeah, external idea something common. Yeah, external takes the name of femoral artery when it crosses the inguinal ligament. Now, mhm, mhm, yeah, like okay. So, lymph node, sorry, yeah, I will be for sure. I wish. Okay, transumbilical plane, transumbilical plane, any lymphatic drainage, any lymphatics above the umbilical plane, it goes to the axillary lymph node, and any lymphatics below the umbilical plane, it goes to the superficial inguinal lymph node. Now, big muscle, pectoralis, pectoralis muscle. That day in the seminar, I got one concept and I like that. Sometimes they can take some fat, subcutaneous fat, where it is not wanted, and they can deposit it where they expect. Uh, yeah, that concept. So, mhm. We are now in the picture, which is shown on the screen, about the orientation of the muscle of anterior abdominal wall. No need to put time here. Directly come to this question. It is important. Layers of the anterior abdominal wall muscle. You can have a look. No, picture down this one. So first will be the skin, then camper fascia, scarpa fascia, then external oblique, internal oblique, transversus abdominis, transversalis fascia, then parietal peritoneum, parietal peritoneum. Then external oblique. Yes, visceral peritoneum, it covers the viscera only. Visceral peritoneum mainly covers the viscera, but parietal peritoneum is the outermost. Uh, how we can say, fluid. Some interperitoneal fluid could be there, and that forms the fold, parietal fold. We will see this. Yeah, yes, very good. Yeah, especially, especially you checked peroneus, peroneus longus, peroneus tarsus, and perineum. You check this part. More and more. I know. Okay. This mhm. This picture is very important and a very good picture. Here, what we need to remember, see, superior epigastric vessel. It arises from internal thoracic artery, which comes from subclavian artery. Okay, so superior epigastric vessel coming from here, and this muscle, this cut section, this muscle, this here is the cut section. Okay, this is the muscle. This is rectus abdominis. Rectus abdominis, we have in between, we have linea alba in the midline. When we do any midline incision, either supra-umbilical midline incision, then actually we go through linea alba so that we are not hampering the muscle as well as any blood vessel. Major blood vessel of the anterior abdominal wall remains inside the muscle, which are superior epigastric vessel, and in the down we will get inferior epigastric vessels. Inferior epigastric vessel means both artery and vein. Okay. Inferior epigastric artery, it comes from where? External iliac artery, right? We have seen in the previous. Okay. And particularly in this part, we can have a look. This looks like a bundle. It looks like a bundle. Here, like a covering. It is covering some muscle fiber, and inside something is there. So this covering is called the rectus sheath. Rectus sheath. Rectus sheath has anterior wall and posterior wall. Okay, up to the arcuate line. Hmm, yeah. So about the arcuate line, all three muscles, external oblique, internal oblique, and transversus abdominis, uh, they form the rectus sheath. How? External oblique remains anteriorly, internal oblique split into two, half part goes anteriorly, half part goes posteriorly, and transversus abdominis, it comes posteriorly to cover the rectus sheath, and below the arcuate line, all three muscle goes anteriorly, and they form only the anterior layer of the rectus sheath, where posterior covering of the rectus sheath remains uncovered or unprotected, but it is covered by transversalis fascia, or it is called fascia transversalis, both are same. Transversalis fascia or fascia transversalis. Just see mhm, anteriorly. Mm. আমি ক্লাসে ইয়ে করে না, শব্দ আসতেছে। শব্দ আসছে অনেক। This oh, no, okay. No, I said this aponeurosis actually gives a chance for expansion when there will be pendulous abdomen. If anyone's tummy becomes enlarged, muscle will never increase. Muscle remains as it is. And muscle fiber, uh, muscular tissue, they are fixed in number. Maximum what they can have hypertrophy, okay, and atrophy, but not the proliferation. But this aponeurotic tissue, there can be proliferation. That's why when there is any someone's tummy becomes larger, this aponeurosis part gives them space to expand. Okay, this is elastic kind of thing. It can expand. So this is one importance. And when people do gym and this kind of activities, see this picture. This is rectus abdominis muscle. In between the muscle, there will be tendinous insertion. When fatty tissue increases, this fat deposits in this aponeurosis. Okay, in this aponeurosis. When if anyone's tummy becomes big, like fatty person, the fat mainly remains in this aponeurotic tissue. That's why if anyone do the gym, we used to call six pack or something. It is because of this aponeurotic tissue or intertendinous insertion. See here, intertendinous insertion becomes more prominent. That's why they look like six pack or something. But muscle remains as it is. Aponeurosis, same like aponeurosis. Yes, yes. Here, see aponeurosis of the internal oblique. Same, there is aponeurosis of the external oblique. Just for the gross concept, this picture is important. Transverse, see the muscle, external oblique, then external oblique coming anteriorly, and it is remaining like this. Then internal oblique, it is splitting into anterior and posterior, two portions. And transversus abdominis, it is going in the posterior. And they are forming the rectus sheath. This is the rectus sheath. Median umbilical ligament urethus, okay. Lateral umbilical fold. Here's something. The medial umbilical fold extends from the apex of the urinary bladder to the umbilicus and covers the median umbilical ligament, a fibrous remnant of the arcus that joins the apex of the fetal bladder to the umbilicus. Remember, when in the fetal life, bladder, urinary bladder of a child, when in the fetus, apex of the umbilical bladder is connected with the umbilicus. In intrauterine life, when the child is inside the mother's womb, child's urinary bladder apex will be connected with the umbilicus, and it is covered by a fold that is called median umbilical fold, which extends from the apex of the urinary bladder to the umbilicus and covers. There will be some ligament, median umbilical ligament. Okay. Usually after the birth, uh, this umbilical fold obliterates. but sometimes it persists, and that's why some children we see when they pass urine, some urine used to come through the umbilicus. Have you seen any of this type of patient? When the child, especially very kids in neonate, day, 1 day or 2 day, 5 days, 10 days, or 1 month, you will get at this age range when they pass urine, urine used to come through the umbilicus. Even sometimes when they pass stool used to come through the umbilicus. It is due to the abnormal communication. It is called fistula. These are called the fistula. No, these structures are called the fistula. But here we are discussing about the median umbilical fold, which extends from the apex of the urinary bladder to the umbilicus during intrauterine life. Different, yes. Median remains in the midline. Okay. And medial lateral, we are familiar with this term. Medial means in the middle side, but not exactly in the middle. Which one exactly in the middle? That is the median. And which is close to the median, that is medial. And which is away from the median, that is lateral. So median umbilical fold is extended from the apex of the urinary bladder to the umbilicus. Mainly it remains in the intrauterine life. And it contains what it contains. It covers the median umbilical ligament, and then comes to medial umbilical fold. Medial umbilical fold, it is lateral to the median umbilical fold and cover the medial umbilical ligament formed by the occluded part of the umbilical arteries. Very easy. Mid, medial umbilical fold contains umbilical artery. Just remember this part. Medial umbilical fold, it covers umbilical artery, and lateral umbilical fold, it covers inferior epigastric vessel and inferior epigastric vessel. So you can repeat content of median umbilical fold. Yes, that's why need to be careful while dissecting this structure, because if lateral umbilical fold get injured, inferior epigastric vessel will be hampered. Inferior epigastric, and it bleeds a lot. It bleeds a lot. So while doing any abdominal surgery, dissection, while doing any dissection, this part to be taken care. Hmm. Any surgery, any abdominal surgery, any inguinal, any hernia, open hernia surgery, open appendectomy. It will remain. It will remain. See, that's why this picture is important. You can see the. You can see the image. Mm-hmm. Yeah. Mm. Yeah, it starts from below the arcuate line because it is connected with the urinary bladder. Urinary bladder will be in the pelvis. No, no, no. It is just in the inner layer, just behind. It remains into pre-peritoneal fat. See, in front of the just for the general concept, in the anterior part of the abdomen, if we cut anything in this midline, here we will not get any external oblique, internal oblique cancer. No, here we will get only the which part. If we cut through this midline, we will get linea alba. If we come little lateral, we will get rectus abdominis muscle. And if we cut here in this part, if we cut here, if we cut here in this part, in the lateral aspect of the tummy, then we will get this three layer of muscle, external oblique, internal oblique, transverse abdominis. But it is not there in the central part. Central part only we have rectus abdominis. Rectus abdominis starts from here. Rectus abdominis starts from epigastrium, from the third process, and it inserts into the pubic bone. Yes. No, no, no. Transverse fascia is whole through. Transverse fascia is whole through. Transverse fascia, transverse fascia is something kind of very tough structure. It is covering the whole abdomen, anterior, posterior, this thing. Extraperitoneal fat, or pre-peritoneal fat, you can say. In that pre-peritoneal, in that pre-peritoneal fold, there will be median umbilical ligament, lateral umbilical ligament, median umbilical ligament, and and importantly, when we do any laparoscopic surgery, when we make any port, that time median umbilical ligament most of the time it gets uh, fires. Sometimes there will be remnant, and it is connected with the liver also, liver fold. We will get it later. Now just focus on this part. Diaphragm. Okay, you can read this diaphragm. Just read. I'm having my breakfast, so I will. I'm listening. You just read. তোমার যাওয়া লাগবে।
আমার যাওয়া লাগবে।
হুম।
ওকে দেখো আমি যাচ্ছি।
কোথায়?
এই আপডেট করছি।
হুম। আমি বলছি যাতে এখানে আমি যখন ডিসিশনে যাবো ওই আসার সময় দরকার হয় ওই আপডেট করে কিন্তু আমরা বের হবো 1:40-এ, ঠিক 1:40-এর দিকে যাতে রেডি থাকতে পারে, ওভাবে সবকিছু করো। ওকে। This part is important. From diaphragm, every time there will be some question. Okay. So what we need to remember, diaphragm, we have three opening. We have three opening. Level 8, 10, 12. 8, 10, 12. 8, 10, 12. 8, 10, 12. 8 is vena cava, 10 is esophagus, and 12 is aorta. I used to remember it as like BOA. B, B, BOA. 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 8, 10, 12. So this 0 is 0. 0, 0. This 0 means 0. Okay. Okay. So T8, this is the inferior vena cava, and it will remain in the central tendon. With inferior vena cava, right phrenic nerve fires as the diaphragm. Very important. These all are the exam question. Then T10. T10 for O, for this 10. 10 contains one O or 0. This 0 you remember, 0 for O. O for esophagus. Esophagus vagus. Esophagus vagus. Remember like this. Esophagus vagus. Esophagus vagus. And it remains in the right crus of the diaphragm. And T12, T12, 12, it is opening for the aorta. And there will be azygous vein and thoracic duct. Azygous vein, thoracic duct. This all you have to remember. Now, diaphragm, it inserts diaphragm origin. Diaphragm origin, it has three. One is external part, costal part, and vertebral part. External part, it originates, you know the diaphragm. Diaphragm, you can have a look. See, diaphragm, it is starting from here like this, and it is going to the back. Okay. In the front, we have xiphoid process here. So xiphoid process of the sternum, inner surface of the xiphoid process of the sternum. This is the sternal part. Then the costal part in both sides, costal margin. What we have? Lower six costal cartilage. Lower six costal cartilage. And it goes up to the back. When it goes into the back, we have what? We have vertebra, lumbar vertebra. We have lumbar 1, 2, 3. In the right side, lumbar 1, 2, 3, and in the left side, lumbar 1, lumbar 2. Finish. Okay. So anteriorly, you can say anteriorly or sternal part. This is the sternal part. Which part? Xiphoid process. Then costal part. Costal part is lower six costal cartilages. This is lower six costal cartilages, where it goes up to here, and here. And this comes the posterior part, where we have lumbar 1, lumbar 2, lumbar 3. Body of the lumbar 1, lumbar 2, lumbar 3 in the right side. This is the right side. And in the left side, it will come up to lumbar 1 and lumbar 2. This is the attachment of the diaphragm. And here we have one opening. This is aortic opening. It remains in the posterior part of the diaphragm. Then we have esophageal opening. It remains into the right crus of the diaphragm. See, in the right crus of the diaphragm. And here we have the central tendon of the diaphragm. Here we have vena cava opening, inferior vena cava. And with the inferior vena cava, we have right phrenic nerve. With the esophagus, we have vagus. Esophagus, vagus. Okay. Esophagus with anterior and posterior vagal tract. Very important. Esophagus with anterior and posterior vagal tract. Then inferior vena cava with right phrenic nerve. And it remains in the center. Right phrenic nerve comes through the inferior vena cava, but left phrenic nerve, you see here, left phrenic nerve, it directly pierces the diaphragm. It is not coming with any of the opening. Left phrenic nerve directly pierces the diaphragm and it goes to the abdomen from the thorax. This is a nice picture. This is subclavian artery. Okay, subclavian artery giving branch. Which branch? This is. Can you guess? This branch is internal thoracic artery. Internal thoracic artery. You are getting the point or what? Better you can look to the screen. This screen. Then it will be easy. At the same time, if you go through your PDF, it will be distracting for you. Okay. So again, in the central tendon of the diaphragm, we have inferior vena cava. Inferior vena cava. With inferior vena cava, here we have right phrenic nerve. So inferior vena cava and right phrenic nerve, they both remain in the same opening. Finish. Then it is at T8 level. Then come little down will be T10. This is esophageal. Esophageal, it remains in the right crus of the diaphragm and it has esophagus with anterior and posterior vagal trunk. Esophagus with anterior and posterior vagal trunk. Okay. And then come to the last opening, that is aortic opening at T12. After T12, which vertebra? Okay, then come to the down. In this picture, you can see left subclavian artery. Left subclavian artery, from here we are getting internal thoracic artery. Okay, internal thoracic artery. You remember we got superior epigastric vein, inferior epigastric vein. So superior epigastric vein, it is coming from where? Internal thoracic. Yeah. Internal thoracic. It is coming from where? And internal thoracic coming from? Internal thoracic coming from where? Subclavian. And here you can see the diaphragm, nice diaphragm. This is the diaphragm. Anteriorly, it is touching with the xiphoid process of the sternum, right? Cut section. And this is vena cava opening. Then this is esophageal opening. And posteriorly, this is aortic opening. Sorry. If you say anteriorly, posteriorly in this pattern, then you can say anteriorly with the xiphoid process of the sternum, posteriorly with the lumbar vertebra in the right side, lumbar 1, 2, 3, in the left side, lumbar 1, 2, and laterally lower 6 costal cartilages. I know. No. This is very important. Shape doesn't matter. Yeah, you see, this is important. Inguinal canal, very, very important. very important. Inguinal canal. Already we have studied. Hmm? We done? Hmm. Yeah. Yeah. Finish. Just tell me diaphragm opening and content rapidly. Yeah. Yes. No, it's okay. If you want to revise this part again, you can have a look of my YouTube channel. I will keep the link right below here. Yeah. Okay. Inguinal canal. You can see the timer on the screen. So it's paying actually. Every minute will be paid. Inguinal canal, anterior superior iliac spine, and pubic tubercle. There is a ligament or there is a connection. This is called inguinal ligament, which is formed by the inguinal ligament is formed by the aponeurosis. Very good. External oblique aponeurosis. Now, see, this is if you remember femoral triangle, we had base, medial border, lateral border. This is the primary level study. Already you studied in your MBBS, right? So now come to the next. Deep superficial inguinal ring and deep inguinal ring. Superficial inguinal ring on the screen. On the screen, superficial inguinal ring, superficial inguinal ring, a ring which lies just above the pubic tubercle, and it is formed by the external oblique aponeurosis. These two information we need to receive. Superficial ring location just above the pubic tubercle and uh, and it is formed by the pubic tubercle and it is formed by the external oblique aponeurosis. This is superficial ring, and the deep ring just above the midpoint of the inguinal ligament. Deep ring just above the midpoint of the inguinal ligament. It is formed by the aponeurosis through the transversalis fascia. Transversalis fascia. Mention the femoral artery name. deep ring. See the if you remember the layer, you remember skin, scarpa fascia, Kemper fascia, then external oblique, internal oblique, transversus abdominis. After that, transversalis fascia. The last one was peritoneum, right? Before the peritoneum was the transversalis fascia. So it is transversalis fascia is the deep structure actually. So deep ring is formed by the deep fascia. Very simple. Deep ring is formed by the deep fascia. Deep fascia which was transversalis fascia. Okay. And where is the location of the deep ring? Deep ring located just ab- above no deep ring just above the midpoint of the inguinal ligament. Yeah. Yes. Okay. Because above the inguinal ligament, it will be external iliac. Remember external iliac? When it crosses the inguinal ligament, then it becomes the femoral artery. That's why at this point, you can palpate the femoral artery. When you do femoral catheterization, this is a landmark. So anterior superior iliac spine and pubic tubercle, this is the midpoint, and just below 1.25 centimeter below is the femoral artery, and just medial to femoral artery will be which one? Very good. You got a very good teacher. Okay. Maybe teacher likes that. Okay. Boundary of the inguinal canal. Inguinal canal. This is very important. Another boundary of the inguinal canal. Mm, yes. This is the tunnel. This is the tunnel between the deep ring and superficial ring. Deep ring and superficial ring. Inguinal canal. Finally, explain the inguinal canal is an oblique communication between the deep and the superficial inguinal ring formed by the arching fibers of the transversus abdominis and internal oblique muscle. You remember the muscle external oblique, internal oblique, transversus abdominis, then transversalis fascia. Now see the anterior. You can see now the boundary. In the anteriorly will be the external oblique aponeurosis because it is anterior. Then the posterior wall by the transversalis fascia because it is in the deep, and floor. Floor will be the inguinal ligament, and the roof by other two layers of the muscle, that is transversus abdominis and internal oblique. Simple, I think. Very simple. No, no. Rectus sheath only cover the rectus abdominis muscle. You can have a look how it looks in your WhatsApp. You can open and just can check. Can you check in your WhatsApp? The last one. If the content, in case of male, there will be spermatic cord and ilioinguinal nerve. Spermatic cord and ilioinguinal nerve. In female, round ligament of uterus, round ligament of the uterus, and the ilioinguinal nerve. Hmm? Okay, you can have a look now. It's running. Yeah. No, I send the link. Mm-hmm. You can open and check. Mm-hmm. Okay. No, I did some engineering as well. So we got inguinal canal, and in inguinal canal we have just 40 minutes remaining. Okay, let me take the upper hand and let me finish. We are now in page number 22. Have to go 71. If you require any part, you can again go through the YouTube and you can watch it. Okay, so we got inguinal canal. In the inguinal canal, contents are important. In case of male, there will be spermatic cord, and in female, round ligament of the uterus. And common in both male and female, this is ilioinguinal nerve. Ilioinguinal nerve. So in the inguinal canal, in case of both male and female, there will be ilioinguinal nerve, and for male, there will be spermatic cord, and for female, round ligament of the uterus. Spermatic cord has three covering. This is simple question. External spermatic fascia, hemispheric fascia, internal spermatic fascia. Yes. Okay. Now this picture again, overall, whatever we studied last 40 minutes, this is the summary, kind of. First layer we have, you just follow the screen where I am doing the marking. External oblique muscle, then we have internal oblique muscle, then we have transversus abdominis muscle, then we have transversalis fascia. So external oblique, it is forming the superficial ring. Finish. And deep one, transversalis fascia, it is forming the deep ring. Deep ring. Yeah. And now see these two will finish. Superficial ring and deep ring. Deep ring is formed by the transversalis fascia. TF, I used to remember it like TF, Taft doctor. Doctor is DR. DR is deep ring. And TF is transversalis fascia. TF, Taft doctor. Rough and tough doctor. It's Taft, TF, transversalis fascia, and DR is doctor. The doctor is deep ring. Deep ring is formed by the transversalis fascia. And in between these two fascia, these are the two layers in between these two. And these two actually form the roof. Okay. So we have anterior wall, posterior wall, roof, and the floor. Floor is by inguinal ligament. Very simple. Easy. Okay. posterior along the way of roof and it is easy. If you understand, it is easy. If you don't understand, again come back to it. This is important. We need to know. Now, this is the anterior view. You are observing someone who is standing in front of you, whose skin, superficial fascia, carpa fascia, these have been removed, and now you have the vessel. This is pubic tubercle. This is pubic tubercle. Okay, pubis bone. This is pubic tubercle, and this muscle is rectus abdominis muscle. Rectus abdominis muscle. It is joining with the bony pubis. Here we have some vessel. This big one is which one? External iliac vein. Okay, this blue color big one, external iliac vein, and this red one is external iliac artery. You are getting the point or me? External iliac artery giving branch to which one? This red vessel, external iliac artery giving a branch which is going upward. This is inferior epigastric inferior epigastric artery, and this external iliac vein also giving inferior epigastric vein. Now, this is the lateral border of the rectus abdominis muscle. Okay, and this is inguinal ligament, and this is a border which is formed by the inferior epigastric vessel. So, inferior epigastric vessel, inguinal ligament, and lateral border of the rectus abdominis muscle, they are forming a triangle. This triangle is called Hasselbalch's triangle. Hasselbalch's triangle, or femoral and perineal. These are very favorite. Everything perineal and femoral. Yes. No, muscle is there, but the covering of the rectus sheath is not there posteriorly, but anteriorly it is there. If you cut, no, there will be muscle. Rectus abdominis muscle. That's why I told you. That's why rectus abdominis starts from here. From here it goes up to the pubic tubercle. But the coverings, just like the shirt, t-shirt, it remains only in the anterior layer. But behind the muscle there is no t-shirt. Okay. Hasselbalch triangle. It is important. This is only. Mhm. This and superior laterally inferior epigastric inferior epigastric vessels, yeah. So in this area there is no muscular part. Here you can say there is no muscle, only the aponeurosis. Here in this triangle there is no muscle actually anatomically, only there is some aponeurosis, and that's why I told you this aponeurosis has the potentiality of the expansibility. They can expand, and they are ultimately the weak point. So any pressure inside the abdomen can come through this. So through this point there could be hernia. Okay, abdominal the hernia which occurs, femoral hernia, Inguinal hernia. Sorry, inguinal hernia. Inguinal hernia occurs through this weak point. If it directly comes through this part, it is called direct inguinal hernia. Okay. And here we have one vessel, pubic branches of the inferior epigastric vessel. Pubic branch of the inferior epigastric vessel. Inferior epigastric vessel. We have inferior epigastric vessel, and from the inferior epigastric vessel there is some branches which is leading to the pubic region. Those are called pubic branches of the inferior epigastric vessel. So again, very nice picture. A very nice picture. So you can see this is deep inguinal vein here, and here we have superficial inguinal vein. Okay, and very carefully listen and try to remember. Deep inguinal vein. See the anatomical location. This is deep inguinal vein, and this is the external iliac vessel. Okay, external iliac artery, external iliac vein. Okay, just imagine deep inguinal vein. It remains lateral to the external iliac vessel. Clear? Deep inguinal vein will be lateral to the external iliac vessel. Okay. Here again you can see this is the vessel, but deep inguinal vein will be here, and it is lateral, means outside of the inguinal external iliac vessel. Okay, just remember this part. Why? Indirect inguinal hernia, how it occurs? We have studied deep ring and superficial ring. We have studied deep ring and superficial ring, which is ultimately forming a canal, inguinal canal or inguinal tunnel. So hernia entering into the deep ring, then it is coming through the tunnel and coming out through the superficial ring. If any hernia occurs like this, then it is called indirect inguinal hernia. Indirect inguinal hernia. And if any hernia occurs directly through the Hasselbalch triangle, it is called direct inguinal hernia. Hasselbalch triangle will be inferior to the epigastric vessel. This is Hasselbalch triangle, this part, which is formed by the inguinal ligament below and laterally by the lateral border of the rectus abdominis muscle and superiorly by the inferior border of the inferior epigastric vessel. If hernia occurs through this triangle, it is called direct inguinal hernia, and if it occurs through the inguinal canal, which is lateral to the external iliac vessel, is called indirect inguinal hernia. Very good. Direct inguinal hernia represents 80%. Direct inguinal hernia represents 80% in children. For pediatric hernias, a herniectomy Without mesh is sufficient as take a surgery. Below 1 year, repair it urgently. Above 1 year, repair it electively. Mm. If you see any hernia below 1 year, mhm. Direct, indirect is more common than direct. This is my technique, my minimum. Uh, because no need of any mesh for the child. Just we can do mesh is a support like the aponeurosis. Mesh is artificial aponeurosis. Okay. No, due to their aponeurosis is not well formed by this time. That's why. Hey, no, no.
থাকা ল্যাংটা হয়ে আমাকে তো করেন হাজারবার না করছে যে করে হাঁটতে
না বাবা কি করতেছে এখন? এখন যাও 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 যাও। দাদা সব লড়মাড় করে দিবে, ক্যামেরা ফালাই দিবে। ওদিকে যাও বাবা, যাও।
ওই ঘরে কি রাখো যাও এই যে পেন্সিল না এনো এই যে
ওকে নিয়ে যাও। ওকে, লিটার হার্নিয়া। ওকে নাও, চিল্লাচ্ছে। Okay, okay. This Meckel's diverticulum, when hernia will contain Okay. Okay. Okay, now Meckel's diverticulum. Here, no need to go through everything. Just Meckel's diverticulum, a specific type of hernia. Okay, if it is Meckel's diverticulum, then it will be called Litter's hernia. If they contain only one side of the bowel wall, which may become strangulated, it will be called Richter's hernia. Richter's hernia. And Spigelian through the linea semilunaris requires repair due to the risk of strangulation. It is called Spigelian. Specific this three type of hernia you need to remember. One is Litter's hernia, most common. Question. If the hernia contains Meckel's diverticulum, it is called Litter's hernia. And if it contains only one side of the bowel wall, it is called Richter's hernia. And if it occurs through the linea semilunaris, it is called Spigelian. Okay. Understand? Just type of the hernia you try to remember. Litter's hernia, Reiter's hernia, and linea angularis. Then these three terms, gastroparesis, exomphalos, these two. Gastroparesis means isolated abnormality where bowel lies outside of the abdominal wall through the defect located to the right of the umbilicus. If there is any abdominal wall deformity which is right to the umbilicus, then it is called gastroparesis. And if it is through the umbilicus, it is called exomphalos. Again, gastroparesis, if there is any abdominal wall defect or deformity right to the umbilicus, that is called gastroparesis. Bowel lies outside of the abdominal wall through the defect located to the right of the umbilicus. Remember the location, right to the umbilicus. Right to the umbilicus, it is called gastroparesis. Right to the umbilicus, gastroparesis. And through the umbilicus, it is called exomphalos. Exomphalos has two varieties, minor and major. If it is less than 5 centimeters, minor, more than 5 centimeters, major. Now, scrotal and testicular anatomy. If you remember anterior abdominal wall layers, this will be very easy. Spermatic cord formed by the vas deferens and is covered by the following structure. Origin, you first look for the origin. External oblique aponeurosis, then internal oblique and transversalis fascia. External oblique, internal oblique, and then transversalis fascia. There is no transverse abdominis. You remember the layer of the anterior abdominal wall? Can you tell me the layer of the anterior abdominal wall? Yeah, that one I mean. Why? Okay. Continue. Then anteriorly we have this structure, bile duct to the right, portal vein behind, and hepatic artery to the left. Then posteriorly, you can see this picture. Posteriorly, this big structure. What is this big structure? Posteriorly, inferior canal. Very good. And superiorly, we have caudate, yes, caudate lobe of liver. And inferiorly, first part of the duodenum. Inferiorly, first part of the duodenum. This is called Pingel's maneuver. By Pingel's maneuver, through this arrow, surgeon can put their finger to do the obliteration of the compression. Yeah, compression. What? Yes, common. Not vena cava. Vena cava. We have to compression. Yes, hepatic artery, portal vein, and common bile duct. This is the maneuver. Because surgeon like you, maybe by mistake, they cut the hepatic artery. Yes. So now you are feeling you are doing something. You are learning. I mean, you are on the process. Mhm. Hmm. Winslow or omental foramen or foramen of Winslow, and the maneuver is called Pickles maneuver. Hmm. Now have a look of this picture. This is how Singles maneuver is performed. Then we are only in page number 32. Okay. If you are, you can call me. I will come. Yeah, I will be there. Yeah, there is no average. I learned everything. I learned. Yes. Anatomy is the father and mother of surgery. Add any prefix. Add any prefix before the word you say. Prefix, suffix, prefix. Suffix which we add after the word. Yes, and prefix we add in front. Abdominal aortic branches, very important and very nice. Okay, you need to remember branches, their level, they are paired or unpaired. Branches, inferior phrenic at the level of T12. Inferior phrenic. Phrenic means diaphragmatic and it gives supply to the both sides. So it is paired. Okay, it is paired. Paired. Inferior phrenic. Just remember, abdominal aorta cross the diaphragm at which level? Hmm? Which one? Paired means two. Could be. Paired means two. Here is the opening of abdominal aorta. And just after opening, they are giving one side, right side and left side, two. So this is inferior phrenic artery at the level of T12. Then we have celiac trunk, very important at the level of T12. Okay, celiac trunk. This is celiac trunk. Celiac trunk at this level. Celiac trunk. This is celiac trunk at the level of T12. Both inferior phrenic artery and celiac trunk both are at T12. Then we have superior mesenteric artery at L1 while reading the transpyloric plane. We studied that superior mesenteric artery, also splenic vein and inferior mesenteric vein, uh, splenic vein and superior mesenteric vein join together to form the portal vein at this level L1. So superior mesenteric L1. Now come to inferior mesenteric L3. Superior mesenteric L1 and inferior mesenteric L3. Okay. So we have inferior phrenic, celiac, superior mesenteric, then inferior mesenteric. Superior mesenteric L1. What else we have in L1? Medial suprarenal. Very important. Medial suprarenal. As renal means it is related with kidney. So kidney will go both sides. Superior mesenteric single. So it is unpaired. Celiac also single, it is unpaired. Okay. Then renal. Renal means kidney. Kidney has both sides, lumbar one, lumbar two. Then in case of male, testicular or gonadal. In case of female, it is ovarian. OVARIAN. This is ovarian. It is at the level of L2. You there? Hmm. Okay. Then median sacral lumbar 4 and common iliac. Median sacral will go in the posteriorly and common iliac at the level of common iliac. Common iliac at the level of L4 and median sacral at the level of L4, but median sacral will go posteriorly. Okay, and common iliac will remain anteriorly, but both are in lumbar 4 level. Okay, once again, no, it is posterior, posterior, median sacral, posterior, median sacral, posterior, and common iliac remain anterior. Here, mainly you need to know the level. L4 level 2. One is termination, which is common iliac. Another one is median sacral, which is the only posterior branch of abdominal aorta. Median sacral. Then L3 only one, inferior mesenteric artery. We have lumbar 4 actually, lumbar 1, 2, 3, 4, because it starts from lumbar 1 and at every level it gives 1. Here you can see lumbar 1, lumbar 2, lumbar 3, lumbar 4. Okay, at every lumbar level there will be lumbar artery in the right side one, left side one. So lumbar 1, 2, 3, 4. This is paired. This is paired. Okay, this is very important, and from here you will get one question. Once again, abdominal aorta, when it passes the diaphragm, it has two branches immediately after the diaphragm, which also gives supply to the diaphragm, that is inferior phrenic. Then anteriorly, we have celiac at the level of T12. This is single. Then we have superior mesenteric L1 and middle suprarenal. Middle suprarenal. Suprarenal gives supply to the adrenal gland. Suprarenal gives supply to the suprarenal or adrenal gland. We will get it. Adrenal gland, it has both sides, so it will be paired. Okay. Superior mesenteric single. Then we have renal. Renal also in lumbar, either one or two. Renal in either one or two. In right side, it is L2, and in left one, it is lumbar one. Okay. Okay. So lumbar, we have lumbar 1, 2, 3, 4, and renal in left one L1. So remember we said in left one L1, left one L1, left one L1 means in the left side it will be in the L1 level, in the right side it will be in the L2 level. That's why renal, they gave both L1 and L2. Testicular or ovarian. Testicular in case of male and ovarian in case of female, it comes from the lumbar 2. Then lumbar 1, 2, 3, 4, and inferior mesenteric lumbar 3. Superior mesenteric lumbar 1, inferior mesenteric lumbar 3. Then 2 at the lumbar 4 level, median sacral and common iliac. Finish. You need to go through it again and again and again. Very important. Come down to the vessel. Abdominal aorta, and in terms of vein, it will be inferior vena cava. So inferior vena cava, mhm, means lumbar 1. Here will be right side 1, left side 1. Number 2, 2. Number 3, 2. Here also 2. Okay. Don't say 8, it is 4. Paired. 8 you will be again confused. Mhm. Then inferior vena cava. Inferior vena cava comes through the vena caval opening at the level of T8. Okay. And after coming, they give the branch inferior phrenic as like the artery. Artery was inferior phrenic artery, and in case of vein, it will be inferior phrenic vein. Inferior phrenic vein, right? Inferior phrenic vein at lumbar thoracic gate. Inferior phrenic vein at thoracic gate. Inferior phrenic vein. Okay. Other veins are at lumbar 1. In between, there is no branch. Right suprarenal L1, right gonadal L2, then it has also number 8, like 1, 2, 3, 4, and here will be the 5 lumbar vein. Okay, very careful. In right side only we have right gonadal, right renal, but in left side you can see left suprarenal joining with the left renal, left gonadal also joining with the left renal. Then it is coming to the inferior vena cava. But in the right side, all are joining with the inferior vena cava individually. Like right suprarenal, directly it is joining to the inferior vena cava, right? Then right gonadal, it is directly joining to the inferior vena cava. But in left side, right suprarenal first joining with the left renal, left gonadal joining with the left renal, then left renal joining with the inferior vena cava, and then it is terminating at the L4 by two right common iliac vein and left common iliac vein. Common iliac vein again dividing into right external iliac vein, right internal iliac vein, like the artery. Okay. Now here is the branches. In short, everything is written here. You can have a look from here.
That picture is not there. I'll go Google it.
Mhm. Abdominal aorta, abdominal aorta, abdominal. Okay. The
So
same
for the
thing.
abdomen and vena cava, I have to know the branches now.
Everything. Everything.
Yeah, and which level and everything. Okay.
Hmm. You can see here it is called Titanic branching or something. Why? Because in the left side you have seen left renal vein. In the left renal vein, left suprarenal vein also come here. It is coming from here. Left suprarenal vein and left gonadal vein. Left gonadal vein. I mean left ovarian vein or left testicular vein. Both they join into with left renal vein. Then left renal vein drain into inferior vena cava. But in case of right suprarenal vein directly will come to the inferior vena cava. Right renal vein directly will come to the right gonadal vein will directly come to the inferior vena cava. Okay,
This all
individual.
this one is known as what? The left side when it all joins together, it's known as left renal. Is it vein?
Hmm. Hmm.
Yeah. And after that, okay, okay.
Here importance is in this part vein
Mm-hmm.
actually very powerful. In this part vein is very powerful. That's why the powerful person remains in forward, as like this picture you can see. Who is powerful more?
The lady.
Yes.
Really?
That's why. Yes. That's why. Just I'm saying. That's why here in front, you can see in the lower part actually artery remains in front. In the lower part, artery remains in front. Okay. But when it goes up, it goes behind the vein. Okay.
So the vein is the girl.
You can say if they just turn their face to do any particular activity, in that case, it will go behind. In that sense, it is like this.
Mm-hmm.
So, vein will remain in front of this junction, only in this part. But all other part, artery will remain in front. I don't know
Mm.
by any means, by any joke, by anything. However you remember, it is up to you. Okay. But Reda, he used to use this picture, this one. Titanic relation or something. You can see here the importance. Why it is? This is abdominal aorta. Okay, very tough structure, and this is superior mesenteric artery, and this is left renal vein. So superior. See, this is celiac trunk at the level of T12. Then at L1 we have superior mesenteric artery. So this is superior mesenteric artery coming. Okay. This is superior mesenteric artery. And behind we have abdominal aorta. And in between we have renal vein. Renal vein. So renal. In front of it will come superior mesenteric artery, and behind superior mesenteric artery will be renal vein, and behind renal vein will be again abdominal aorta. So it remains in between two strong arteries. Okay. Sometimes nutcracker syndrome or one syndrome is there when this renal vein gets less blood supply. Because of this artery, if there is any aneurysm, it compresses over the artery vein, so there will be less blood supply to the kidney. Anyway, now this is colon. We will try to finish in maximum 10 minutes. Peritoneum relation, have to read it very properly. Peritoneal location and left colon. Extraperitoneal rectum. This is important. Extraperitoneal rectum. Extraperitoneal rectum. Extraperitoneal rectum. So, posterior upper third.
Which page is it? Okay. Okay.
Posterior and lateral middle third, whole lower third. Extraperitoneal means without peritoneum. Without peritoneum. Okay. So if this is peritoneum, if this is rectum, suppose this is the rectum, this one. Okay. This is lower one third. This is middle one third, and this is upper one third. Anteriorly, it is whole covered by the peritoneum. Laterally, it is one third, and posteriorly it is whole lower third, whole lower third will be extraperitoneal. From here, exam question will be these branches. The rectum has blood supply. V. Superior rectal artery and inferior rectal artery. Superior rectal artery supply. Superior rectal artery. Okay. Rectum, this part is important. You need to read this part with care. See this picture I drawn before. This is posterior, okay, and this is anterior. Whole the posterior of the rectum, there is no peritoneum, okay.
Yeah.
Then lateral, middle. This is lower one third, this is middle one third, and this is upper one third. Upper one third will be covered by the peritoneum. Upper one third will be covered by the peritoneum, lateral. And anteriorly, middle and upper third will be covered by the peritoneum.
So whole lower third.
And yes, and the lower third of the rectum is bare.
No
without no peritoneum. Now the cecum blood supply Exam question is appendicular artery is the branch of which artery? Appendicular artery is coming from iliacoelic artery. Okay, this is iliacoelic artery. Iliacoelic artery giving supply here and from there. Let's put in appendix. Retrocecal 70%. Blood supply appendicular artery from the iliacoelic artery. Appendicular vein from superior mesenteric vein. Difference between jejunum and ileum. Just you read. And gut embryology. Gut embryology. Foregut, midgut, hindgut. Foregut, midgut, hindgut. Foregut, midgut, hindgut. Foregut. Okay, you remember this part. Foregut. It is from esophagus to the second part of the duodenum. Foregut mainly, you remember from the esophagus. Foregut starts from esophagus up to the second part of the duodenum, above the mesoduodenal papilla. Midgut from the second part of the duodenum to the proximal two-third of the transverse colon, and hindgut from the distal two-third of the transverse colon to anus. This is foregut, midgut, hindgut. Now, foregut mainly gets supply from the celiac trunk. Okay, midgut gets supply from the superior mesenteric artery level L1 and hindgut from inferior mesenteric artery level L3. So foregut from celiac trunk level lumbar coracocecal and celiac trunk branches are left hand side, left gastric, hepatic and splenic, left gastric, hepatic and splenic. These are the branches of the celiac trunk. Then midgut from superior mesenteric artery. Superior mesenteric it has branches: inferior pancreaticoduodenal, jejunal, and ileal branches, ileocholic branches, right colic, and middle colic branches. And hindgut from inferior mesenteric artery branches are sigmoidal branches, left colic, and superior rectal branches. Healthy. This picture you have to see very nicely and you have to understand it. Okay, this is superior mesenteric artery and their branches. First is inferior pancreaticoduodenal artery, then inferior pancreaticoduodenal artery, middle colic artery, then right colic artery, then ileocolic artery, then ileal arterial arteries, jejunal branches.
Where? I'm not seeing that picture. Where is it? Which page is it?
44.
You should have added your own picture, I think.
No, it's there.
No, I don't have it. 44, no?
Yeah, now venous vein is a bit confusing, but we have to remember it properly. Superior mesenteric vein, inferior mesenteric vein, superior mesenteric vein as like superior mesenteric artery. Inferior mesenteric vein also like inferior mesenteric artery, but inferior mesenteric vein in this picture. Superior mesenteric vein, okay. Inferior mesenteric vein join with the spleen. If you see this picture, it is the summary. Inferior mesenteric vein join with splenic vein. Okay, splenic vein is very big. Splenic vein coming from the spleen. Inferior mesenteric vein joining with the splenic vein, but name will not change. Still, the name will remain as splenic vein. Then splenic vein going more medial, then superior mesenteric vein also join together. When superior mesenteric vein join with the splenic vein, then they form even a larger vein which is called portal vein, which is called portal vein. Okay,
Mm.
stomach, stomach blood supply very nicely you have to study. This is celiac trunk. From the celiac trunk, main branches are left hand side, left gastric, hepatic, and splenic. This is the main source of blood supply of the stomach. From the left gastric, again it will divide into esophageal branch and it will come down. We will see. So left gastric, it is giving mm, okay. Just take it with a very shortcut. In part B, we have to read this elaborately. Left gastric artery, it is coming from the celiac trunk. Then common hepatic artery also giving. Oh, it is 1:45.
Oh yeah. You want to
I have
stop
to
and
get.
we'll continue later?
You can just read rapidly and finish.
Okay. 1:45.
Hmm. Okay, then you can complete the remaining part by yourself and finish. Okay.
Okay. Anything that's important for exam? Any pages? Any
So
topics?
whole as a whole, have to read. Abdomen is very important and you cannot uh, skip. Have to read all.
Okay.
Okay.
Well, I will do myself.
Mm-hmm.
If anything, I will ask. Okay.
Mm-hmm.
Okay. Thank you very much.
Yeah,
You're going to work now?
yeah. I need to get ready. Then my duty will start actually from 3. But the pickup
Then
car used to take around 2 to 10.
okay.
I will get ready.
Then you'll send the link. We will study your word. I mean, like you will do your work. I will do my work.
Mm-hmm.
You'll send the link. We will study.
Mm-hmm. Okay.
Okay.
Yeah, yeah.
Okay. Then I see you later.
You continue. You try to finish the maximum you can. There is not much left. Whatever been already discussed, you can go through it
Study.
rapidly, and the remaining part also you can see. Okay.
Okay.
Yeah.
Okay.